Okay.
How are things going for you?
We're, this is our finals week
Yeah.
actually, so we just got started actually, but we're
Yeah. Okay.
yeah, yeah.
Okay. Well, good luck.
Thank
Not
you.
that you need it.
Yeah. Thank you. Is it okay if we get started?
We'll
I
get
guess.
started with this interview, right? Please.
Okay. Yeah. So, before we actually get started, talking to Peter, here's a quick description about him. So, Dr. Peter DePergola II is a distinguished figure within the field of neuroethics, holding multiple roles in bridge academia, clinical practice, and organizational leadership. He's a chief ethics officer and senior director of clinical and organizational ethics at Baystate Health. Dr. De Pergola's academic journey includes a bachelor's in philosophy and religious studies from Elms College at MTS in ethics and Boston College, and a PhD in healthcare ethics from Duquesne University. He has also completed advanced training in neuroethics at institutions such as the University of Pittsburgh School of Medicine, Tufts University School of Medicine, and Harvard Medical School. His research interests encompass the neuroethical implications of memory, manipulation, narrative identity, and the metaphysics of hope. So I guess we could get started now. First question that we have for you is, can you share one of the main pivotal moments in your academic career that has led you to specialize in neuroethics?
Yes. Well, thank you, first of all, for the wonderful invitation to be here. And it's really a privilege. I'm very grateful for the work that both of you do. So thank you for doing this. Um, for me, part of the pivotal moments of sort of discovering neuroethics was always a fascination with neuroscience growing up, and really not knowing how I wanted to pursue that, whether that's through the sort of a strictly clinical lens or more of a theoretical lens. Studying philosophy opened me to ideas like philosophy of mind, philosophy of consciousness. And then the study of ethics really encouraged me to think about how those big questions in which I was interested could really be applied to patients at the bedside. And so once I got into doctoral studies in healthcare ethics, I focused specifically on neuroethics, which focuses, as your listeners know, on the neuroscience of ethics. How are decisions made and how are they explored? How do we know that they're justified? And then sort of the ethical issues within neuroscience. Should things like deep brain stimulation exist? Or neuromodulation or neuroenhancement, things like that. So I became fascinated really with ethical implications of neuroscience and the neuroscience of ethics. Um, I was always interested in neuroscience because it's the only organ that we have in our bodies that can contemplate itself. You know, our heart can't think about our heart, our lungs can't think about our lungs, but our brain can think about our brain. That's sort of unique. And I felt like if we better understood those issues, we could really um, do a lot of good, both theoretically uh, in terms of academic pursuits, but also clinically in a meaningful way in the lives of patients and their families.
Awesome. And it's also like great to hear that actually that how you initially got interested into neuroscience and kind of leading towards your journey in neuroethics. So I guess we're gonna like slowly kind of like gear towards ethics, but before we get there, in your book Forget Me Not: The Neuroscience Case Against Memory Manipulation, you argue against the intentional erasure of episodic memories. Would you be willing to elaborate more on the ethical dangers you associate with that?
Yeah, absolutely. I'd be happy to. So um, that particular text is a revised form of my doctoral dissertation that I wrote under two sort of distinguished individuals in the world of bioethics. Gerard McGill, originally from Scotland, who's at Duquesne University in that Doctor of Philosophy and Healthcare Ethics program, and then the director of the Center for Global Health Ethics at Duquesne was Hank Ten Habe, who's a physician and also um, a PhD philosopher who is very interested and supportive of my pursuit of those topics. So what I really did at the beginning of that text, and before that, the dissertation was really to write about how I thought um, editing negative memories, specifically related to things like post-traumatic stress disorder and substance use disorder, could be justified. So I set out uh, thinking that I was going to argue in favor of limited use memory manipulation for things like um, issues in post-traumatic stress disorder, like torture, sexual assault, really nefarious things that the memories of which really could not, in my mind at the time, lead to anywhere good.
Yeah.
The more research I did, the more I struggled with that justification. And the reason I struggled with the justification was because I realized that even those memories of negative traumatic events would not be able to be completely uncoupled from the other memories we have, autobiographically or episodically, that are tied to things like our emotional rationality, how we make sense of the emotional commitments in our lives, or of our narrative identity, who we understand ourselves to be. And when we think about the development of moral character, typically it's the result of some sort of negative event. And so what I didn't want to do is say that negative memories are good. I don't think that negative memories are good. What I tried to argue in the book is that removing even negative memories is worse than having them to begin with. And that's not the same thing as saying that negative memories are good,
Right.
but rather that removing them, if that disables us from being able to seek, identify, and act on what's good, that would just simply trade problems. We'd be taking one terrible thing and trading it with another terrible thing. So if I could go in through deep brain stimulation or electroconvulsive therapy, um, false memory creation, and I could detach the emotional response that I have with particular negative memories, and I could solve that problem, but it would also disenfranchise me from participating fully in my relationships with my family or my friends. So that when I see something really terrible happening, I don't have the same emotional response like we often try to do in the early psychopharmacologic interventions on able-bodied individuals in combat warfare. So what we realize is that again we sort of traded problems, and so I looked at the Parkinson's disorder literature and looked at electroconvulsive therapy and how that often solved one physical problem but created another. It disassociated emotions that were positive in that individual's life from their ability to act on those things. And so, yes, it did solve one problem, but it created another that's arguably worse than the initial one.
Yeah. Wow. That's actually like very interesting. I think like solving these types of dilemmas is like very powerful and like it just definitely shows like the amount of like skills that you have like built over the years. Um, like coming like bridging from that, like as the main like chief of ethics and consultation service at Baystate Health, how would you say that like you're able to like approach these types of dilemmas and like how do you first like encounter them and how do you like solve them?
Yeah, thank you for the question. So the ethics consult service at Bay State Health receives anywhere between 1,600 and 2,000 consults per year. So it's a busy clinical service. I'm a party of one in that service, so I deal with all of those consults. And it could be anything from the very beginning of life or even prenatal life in OBGYN all the way through geriatrics in every sort of individual discipline in between. I personally find the most interest in neurocritical care issues where we're talking about things like traumatic brain injury, brain death, locked-in syndrome, different sort of neurological disorders, disorders of consciousness. But really, the key to responding to all of those clinical cases is really to be not just able to have the skills to meet patients and families where they are, but to have the willingness to enter into their chaos. So to first humble yourself, to be willing to meet people where they are, hear where they're coming from, ascertain their values, and then work with the clinical team to pair the best of clinical expertise with the best of patient values so that we can have truly shared decision making. Once we know the clinical limitations and really the patient preferences, then we can navigate the mean between those two extremes, the possible on one end and the permissible on the other.
Yeah, that's great. And also to follow up on that, right? So since Baystate Health like tailors to, as you said, like thousands and thousands of clients, and there should be like, sometimes scarcities in terms of resource, especially like, during the pandemic when people suffered a lot of mental issues, in addition to physical problems. In those cases, when you had to make those difficult decisions on resource allocations, what ethical principles primarily guided your stance in those like
Yeah.
situations?
Yeah, so I was responsible and early on in the pandemic, I was appointed by the governor of Massachusetts at the time, Charlie Baker, who's now the president of the NCAA. So quite a shift in job roles um, to develop for the state a scarce resource allocation triage protocol. And so when I worked with a group, I was the youngest person on that group by about 20 years, but worked with several other seasoned colleagues to sort of develop how would we make these decisions based on what, how do we address things like equity that we know we have issues with. And in Springfield, Massachusetts, which is in the western part of Massachusetts, it deals with a very low health literacy, very high poverty rate. So we really are treating, we have a health safety net hospital treating the poorest, the most health illiterate in the state. So how could we, in a community that historically we have given a lot of reasons to distrust us, how can we make sure that they recognize that we're doing the best we can with what they have? So we developed basic non-negotiable principles like sort of clinical equity, that things would be allocated to individuals based on need, not based on individual role, not based on things like race, sexual orientation, anything else similar, that we would really focus on whether or not a particular intervention could confer a net clinical benefit to the patient. So there was a heated debate at the state level about whether age should come into this equation, whether we should prioritize those who were younger versus those who were older. So we ultimately decided against it. I didn't think that it was a good criteria. That works if everybody is at the same level of health, but we have some patients who are 9 years old with terminal cancer and others who are 85 years old who are in relatively good health and in much better health. And so just doing it based on age was short-sighted. And so what we needed to do was create sort of a comprehensive algorithm where we used both a SOFA calculator, sequential organ failure assessment calculator, as well as the Glasgow coma scale. We put those together. They're not meant for resource allocation issues, but they're the best tools that we had, and we were working with imperfect means at the time. So we use those things, but then recognize that there was intrinsic bias even within those systems. So we knew that the SOFA score focuses a very high amount on BUN and creatinine level, kidney function level. But in the communities that we serve a great population of individuals of color who disproportionately, genetically, suffer from chronic kidney disease.
Mhm.
And so that if we use that tool indiscriminately, we would be disenfranchising a whole section of the population. So what we did is we identified those shortcomings and then corrected in favor of it. So if we had an individual that was from that community, we added a certain amount of points. So it was a point scale, and then it would be distributed based on sort of the net cumulative scale of clinical net benefit to be offered. So it was imperfect. Thankfully, we did not run out of ventilators, which was very positive. We had much more resource constraint on our ECMO machines, extracorporeal membrane oxygenation machines, heart and lung bypass machines. We only had 6 of those. And as you know, you need a physician and a nurse working around the clock on that machine at all times. So Our scarcest resource during the pandemic was not ventilators like we thought or vaccinations, but really people. We had a lot of sick people out of work at one time and just a mass influx of patients. So um, we were able to use that same model to reallocate our staff and our bedside providers to different units that needed it more. And so it became helpful when we distributed things like vaccinations and everything else. So we still used that same um, we looked at things um, like zip code um, to look at distribution rather than just first come first serve. We know that due to health literacy issues, there's going to be a variety of individuals who are either distrustful or don't get the same access to information. So distributing it based on zip code would make sure that all of the wealthy communities didn't get it before all of those that were more impoverished.
Okay, wow, that's actually like really cool how you guys were able to like solve such a tough problem about like equitable like healthcare, you know. I thought that was actually really interesting. How exactly did you come up with that equation? Exactly, like what are the like, fine details that you guys use to actually determine like what individual gets what healthcare resource versus
Yeah.
another?
So we really looked at yes, we sort of looked at the overall net needs of the individual. So let's say that we were really focused on distributing a ventilator, but we're failing to recognize that the patient was already in multi-system organ failure. So we made sort of a net calculation based on um, not just the general needs of the patient, but how much time would be typically spent on the patient, how long their admission would be, what sort of other things would be necessary. So let's say that we have a ventilator available, but the patient needs 20 different 20 units of blood, right?
Uh,
That would give us pause to say, oh, okay, how do we do that? So we looked at the net need for the patient, the time commitment, um, resource constraint, and then we're able to use the SOFA score and the Glasgow Coma score. And again, the Glasgow Coma score was something that has within it an intrinsic bias against people with intellectual disabilities, right? So they would score low uh, um, on the Glasgow Coma scale, but they would. That's not an accurate representation of sort of what they do and sort of what they need. So we're able to look sort of at the whole thing. So it's a lot of different working parts coming together.
Yeah, thanks for breaking down like the equations, like nitty-gritties for us. I think it's really helpful in terms of like also for other hospital organizations in assessing the needs of individuals. I think there's like a huge trend towards like a value-based care, kind of, tailoring towards like individuals and kind of trying to maximize the utility. I think it's a more like a subtle argument in a way, but I think it's something that we should all think about. And speaking of which, we also wanted to like talk a little bit more about your research. So you are a doctor of theology candidate in neurotheological ethics, and we thought this was pretty interesting because we have come across like many neuroethicists, but I think we haven't really come across a neurotheological ethicist. So how do you like integrate all these like theological perspectives into the neuroethical considerations?
Yeah, so I'm formally trained as sort of I would say, clinical bioethicist or philosophical bioethicist. But in an earlier life, before I sort of transitioned to the clinical world of bioethics, did study sort of theology and ethics. And so I always felt like I had unfinished business there. And so now, sort of in the loads of spare time that I don't have, I thought, why not upset my family further, pursue a second doctoral degree? And so for me, it was sort of trying to go back to some theological roots while still exploring things that I was really interested in. What I became more interested in recent years were things like hyperdimensional consciousness. So basically, wonderful research has been done by the cardiologist Pim van Lommel in the Netherlands, published in The Lancet, a variety of other journals as well, about near-death experiences, individuals post cardiac arrest who have been able to, who have flatlined and have been that way for a period of time, who are ultimately resuscitated, who seem to have gained secret knowledge that individuals would not otherwise have. One story in particular is, and of course, your brain is still working, or can still be working during this period of time, but without a heartbeat or blood flow to the brain, consciousness should not technically exist. But it would be something really specific, like telling a surgical nurse that she lost her engagement ring 3 months ago in operating room three. If she looks under um, the fourth bedpan in the row, she'll find it there, right? Something that the person would have no ability to know. Or on top of the roof in the west side corner, there's a small girl's chain that was lost. Um, so I became very interested in that. I also became interested in the relationship between um, hope, or at least hope as a moral virtue, and neuroscience. And that naturally sort of led to sort of theological commitments, at least when we think about hope a lot. Um, so when I sort of think about hope, I think about it as a neurological gateway virtue that makes other moral virtues possible. So without hope, I don't know that there's really a need for courage, right? Hope, believing in a future possible yet difficult good. Courage, solidarity, um, compassion. Without hope for the future, it doesn't really make sense for that to happen. And so I thought, okay, I'm really interested in working on hope. I can do that in a theological key. I can work on consciousness beyond life, so to speak, and explore really the neurotheological roots of that, which is really a new discipline, uncharted territory, so to speak.
Yeah, that's great actually. And you kind of mentioned that. So I guess like kind of delving more specifically into like the research approach. So do you kind of, I guess, evaluate the different, I guess, like neuroscientific like states of mind between those who believe in God versus those who don't? And if so, how do you like break down those populations? Because there are so many different religions, people have like different beliefs. There are like monotheism, polytheism. So how do you kind of like quantify how these states vary and how it translates to varying degrees of hope?
Right. And so I think which is a great question. I think I'm taking more of sort of a spirituality approach rather than a religious approach. In the distinction between religion and spirituality being my relationship with what transcends my finitude, right? That's general, that could be applied to Hindus or Buddhists or Catholics or Jews or Muslims. Um, Religion being, okay, now what should I do about that relationship? Right? How should I live my life as a response to that relationship? So I'm looking more at my relationship with what transcends my finitude. So from a wide variety of different religious traditions, for those individuals with sort of a belief in um, something beyond themselves, how does hope factor into the way that they make decisions, particularly at the end of life? Are they more comfortable with transitioning to a limited form, comfort measures only, or do they tend to really dig their heels into the ground and say, "Yes, I'd like to believe, but really, I'm worried about that this is really all that comes next." So we're looking at those different populations, but I'm specifically focused on those who have had near-death experiences and how that life after um, that near-death experience looks, both spiritually and theologically.
Wow, that's that's actually really great. When it comes to like actually educating others within the field of bioethics and medical humanities, I mean, I know through your dissertation and through all of the degrees that you've earned throughout the years, you've learned a lot. How exactly do you educate others to prepare them for the field of ethics, and how do you help them face these different challenges within healthcare?
Yeah, it's a great question. Um, I would say on the theoretical realm, I always heed Aristotle's advice that, the sign of an educated mind is the ability to entertain an idea without accepting it, right? So you have to be open-minded. If you go into the field of ethics thinking that you're correct and you're going to find all of the justifications to prove that you've been right all along, you're in the wrong field. So you have to be open to having your mind changed, even if it means that you have to sacrifice a really long-held belief that you had, moving toward now a rational, justified belief rather than just um, sort of a hope that X is true and Y is wrong. So I would say approaching it really with intellectual humility, to really be a student of truth and to understand that something is not true because you believe it. You should believe it because it's true, right? And so, and also recognizing that ethics is very much about identifying not what's clearly good to do versus what's clearly wrong to do. It's often about identifying what's least bad to do, what can be slightly more justified than the alternative. That doesn't mean that you always have to feel good about it, but ethics is very much about trying to identify what's least bad to do, knowing that there's not a perfect solution, that it's not going to end up in a perfect equation where everybody wins at the end of the day. Value is going to be sacrificed somewhere, but how are we sacrificing that value? How are we weighing and balancing that against sort of higher, more important values? And how can we sort of arrange those things hierarchically in a greater value structure that promotes human dignity and that helps us understand that that really is the landmark principle, um, that people that we'll be dealing with are of value by virtue of who they are, not as a result of what they do, right? And so when you look at the patient with alcohol use disorder who's asking for the same organ transplant as the person with who's 13 years old and never did anything wrong, just has a chronic condition, that people generally speaking are doing the best they can with what they have, and we treat people in healthcare based on what they need, not based on what we think they deserve. So we have to check those biases right at the front door, and then be able to proceed with finding the best thing to do and recognizing that a perfect solution is not possible. So starting with intellectual humility and then helping people understand that, a true calling, at least in the clinical ethics realm, is it's not about an ability, but it's about a willingness, which is just a deeper commitment. So it's not an ability to comprehend these things. It's a willingness to enter into that chaos, also having the ability and the skills to help people. Um, I would say the other sort of final reflection there on that particular question is moving away from the popular idea that the truth is sort of relative. I know that that's sort of a popular cultural phenomenon at the point that, it's my truth and your truth, but not the truth. We don't actually live our lives that way, right? That idea that, ethics is relative or it's right for me, but it's wrong for you is based on the idea that the truth is relative. But to disprove that concept, you just have to ask the question to the person who claims the truth is relative. Well, do you think that statement is true? Right. And then they're sort of stuck. They either have to admit that all truth is relative except this one truth, or the truth is relative, including my statement, and it doesn't merit belief. So it's sort of immediately self-defeating, but also, in no way is abuse of children okay for some cultures and not for others, right? There's certain conditions that we would never say, well, maybe that's right for you, but not wrong, but wrong for another, right? And we just know that by human experience. So getting into the comfort zone of saying, the truth is complicated, extremely complicated, and it's not always clear. But we have to admit that it exists, at least in some full, more or less fuller form, in order for ethics to work. Because we can't talk about the right thing to do unless we think that there is some sort of objective. objective morality, even at a very base level.
Yeah, totally. And I was also like kind of enjoy talking about your kind of arguments against like relativism because as you said, it is
Yeah.
quite prevalent amongst these days to kind of think about that, given there are many ways to justify whatever conclusion you may come up with. You can always come up with arguments for it as well as arguments against it.
Yep.
But as you said, it's very challenging to know the truth because truth is sometimes very blurry, and we just have to make
Yes.
like some agreement that we can like agree upon as rational individuals. And with that comes,
Right.
I guess, like cross interdisciplinary like collaborations, right? Because you have to work with many different people with diverse backgrounds to actually understand different people's perspectives and kind of sort of identify like what values are relative versus what values we must like agree upon. For example, like as you said, like abuse of children cannot be tolerated regardless of what cultural background you may come from. Same goes for like saving human lives and providing patients according to their needs, not what they deserve. So my question was, what was like a key experience that you had that really changed your perspective? So maybe you originally thought this was the ethically right way, but after interacting with people from different disciplines, your thoughts have like changed significantly. Have you had those kind of experiences? And yeah, what are your thoughts?
Yeah. Yeah. Certainly. And I see this often. If we were to go on rounds in any of our critical care units, whether it's for adults or pediatrics, neonatal, cardiac, you see in this line of work very similar dilemmas. Families often equating doing more or electing for more interventions as doing better or as being more loving. What loving person can say stop? And that this really is sort of a fundamental human need. Um, so I remember when my son, who's 3 now, when he was 1, he went into the pediatric ICU. He ended up doing fine, but he needed sort of oxygen steroid treatment to treat a severe case of RSV. And I remember thinking to myself, I'm surrounded by my friends that I know very well. I trust them completely. Thankfully, I'm health literate, or at least relatively health literate. I know what questions to ask. I knew with absolute certainty that he was going to be okay and we're going to go home in the morning. But I didn't feel that way. I knew it in my mind, but my emotions couldn't catch up. And if that's how I feel with something as simple as knowing we're going to go home in the morning, how must it be for somebody in a very different perspective? And I think it's easy for us to see a lot of the same cases over and over again, um, and just think that we're dealing with a difficult family who just can't see what we're seeing, and we start to experience compassion fatigue. But what we fail to remember is we could have 10 end of life conversations a day, 10 conversations about the fact that a miraculous cure that um, may not happen, right, is extremely unlikely to happen. We can't disprove that it will happen, but that's not the same as to say that it will. Um, and that can be really draining. You try doing that for a couple of days, try doing that for a month, try doing it for a year, right? It becomes overwhelming. But it's really important to remember, and in my experience with my son helped me to remember that every time we have those conversations with patients and families, it's our 100th time, but it's always their first time. And they deserve for us to approach it like it's the first time, to give them the benefit of the doubt, let them grieve, let them ask questions, let them have that mind heart disconnect. We have that intact. We've seen it a million times. They've never even thought about it before. So it's really those experiences that keep you humble and help you realize that you could understand all of the neuroscience or all of the clinical ethics in the world, but when you're on the other side of sort of those ivory bed rails, geez, it just feels completely different, even if you know that it's not.
Yeah. Yeah, no, I definitely agree with that. Like, especially for individuals that are grieving, um, or going through a situation for the first time, like they could definitely feel like out of place and like not know how to feel. Um, when it comes to situations such as these, has there been any like other experience that has like impacted your approach on neuroethics and just dealing with situations that can be heartbreaking for some families, but need to be dealt with in order to ensure patient care.
Yeah, absolutely. I think one that stands out to my mind is just how important understanding and being receptive of different cultural traditions can be. So recently in the state of Massachusetts where I work, um, and in all states except the state of New Jersey, uh, the diagnosis of death by neurologic criteria is equivalent to legal death, where we issue a death certificate. And so I was consulted to the pediatric ICU recently about a 15-year-old boy who was riding his bike across the street in New York, got hit by a car, unfortunately rapidly progressed to total brain death. It's also important to realize that somebody who has lost irreversible cessation of all portions of the brain, including the brain stem, their heart and their other organs, if they're perfused with oxygenated glycogenated blood, will continue to work with heart and lung bypass machine. Right. So even though we don't know exactly how long that could go on for, obviously we can't run a clinical trial for somebody who's passed away, but presumably that could go on for weeks. Um, that we could still continue to sustain the body even though the brain has died. And of course, it's artificial, and we're sustaining the biological functioning of a person who's passed away. But for this individual family, they were Orthodox Jews. And so, for religious reasons, according to their Hasidic tradition, they refused the diagnosis of death by neurologic criteria, opting instead in favor of cardiopulmonary definition of death. So for them, the patient was not dead. For our providers, we were caring for the body of somebody who had passed away. Right. So how do we weigh and balance these traditions? And so what we ended up doing was trying to contact a hospital in New Jersey, even though, it was against our better clinical judgment. What we wanted to do in providing patient-centered care was realize that probably what was most important for the patient that we felt like we were harming clinically, we were harming the corpse of a patient, was also that his parents thought that they were doing the right thing, that this religious tradition was important to them, it's important to him. We don't have to agree with it, we don't have to like it, but we can facilitate what we think is appropriate. And so we actually arranged sort of a helicopter to take him to a hospital in New Jersey that did accept him. Um, the patient was sustained on that heart and lung bypass machine for about another week and a half. Um, One problem with individuals that are sustained in this way is that the brain obviously controls your ability to fight infections and um, regulate your temperature. And so you'll continue to spike infections that will just eventually become lethal and you'll go into multi-system organ failure. And that's precisely what happened. So we knew that was going to happen. So we recognized that this patient had died, but there was only one outcome that would destroy the integrity of the family. And so we opted to do something that was not part of our um, ordinary clinical procedure in order to make sure that the narrative function of the patient, his narrative value, his religious commitments, who he was as a person, how he understood the world was still held together.
I think it's a very interesting case on, clash of definition of death between legal definition versus the religious definition. And I think a lot of
Yes.
religious communities kind of abide by that, but also at the same time, if you scientifically think about it, as you said, it's only a matter of time. And we also need to think about patients who are actually who actually need those resources to be used on them so that they don't get into like actual like neurological death, which will inevitably
Right.
lead to physical deaths. So I think it's a very interesting thing for us to all think about. And these kind of definite, like these kind of dilemmas and thoughts apply also to emerging, neurotechnologies. For example, we have like Neuralink. We also interviewed previously with Nathan Copeland, who has those implants on his brain. So, what do you think? Like, what kind of roles can ethicists play in terms of balancing all the different explanations slash justifications in terms of regulating these technologies and setting good precedent for public to follow?
Yeah, no, it's a great question. It's something that keeps me up at night. Um, I would say with things like Neuralink, I think the possibilities are incredibly promising. But with incredible promise and incredible advancement, we have to use caution. If we thought about things even like moral enhancement, or wider access to brain function, um, even if we increased our brain function by 5%, I worry that as human beings, we're not sort of capable of handling that. So if you think about all of the things in the world that you're aware of that make you anxious, that keep you up, that worry you, and then we add 5% to that, right? Because with additional consciousness comes perception of all of those extra realities. I really do think that it would drive us sort of mad. And so I do think that we need to draw a line in the sand to say if these things help us to become more fully human, we should pursue them. If we get to a point where we're becoming beyond human or better than human, we really have to stop and think about that. I'm a big fan of the political philosopher Michael Sandel's very small book, The Case Against Perfection, where he sort of illustrates that he is in favor of helping us to become more fully human, removing barriers that are unnaturally sort of in place. But when we become the masters even of our own nature, we're doing something that is sort of perilous and dangerous and is a threat of to the species. So I am very much looking forward to things like Neuralink helping with things like Parkinson's disorder, um, different sort of tremor disorders. It's incredible actually seeing some of how that can be used therapeutically. Um, but when it's used to the end of transhumanism, I do tend to get a little bit worried.
I see. I also kind of read about this interesting research where they didn't use the brain, but they used something called brain organoid, which I believe they use pluripotent stem cells to kind of, make the neurons. Of course, it doesn't have the organization of a human brain, but people have used that to study how those cells can interact with like chips and form, I guess, different reactions, how they react to like those stimuli. And there are some there was one research that I read that kind of talked about they actually were able to observe some potential that the brain cells can actually actively adapt to, I guess, like changes in chips and furthermore kind of integrate that into a greater structure. So I think another question that I may have with regards to in light of this research is that if you think about, as you mentioned, like transhuman, right? So let's say it basically makes like humans like suddenly more like enhanced and in a way that it kind of compels everybody at that point, it de facto becomes kind of like a duty because otherwise you can't like keep up with the rest of the humanity. So that becomes like a complicated situation. And I mean, it has already happened a lot with technology, right? So the gap between the technologically literate versus the illiterate, it's already been like so broad and big. So, what are your thoughts on how, I guess, we should approach these in terms of development, and how do we protect those who choose not to go follow the trend? And yeah, how do
Yeah,
we?
that's really a great question. Really centers on equity again. And that's something that I'm very concerned about. Whenever we have sort of new emerging technologies, it typically benefits those who are able to pay for them. So I can't imagine a world in which Neuralink would ever be inexpensive. And so you're widening disparities between the haves and the have-nots again. Um, I think it also will send sort of contemporary culture, global humanity into an identity crisis where we will be pushed more toward that utilitarian idea that people will be of worth by virtue of what they can do rather than by virtue of who they are as persons. I worry about the implications of that for things like human rights, um, the ability to say no, the ability to be integrated into society that um, is able to afford it or something else. The availability of health access to those who would be able to pay for certain upgrades within the Neuralink system that would never be possible for those with economic constraints. So if Neuralink can be used in a way to help create equity, I think that that's wonderful. If it's used to sort of widen the disparity, I think that we've misused it. Just like I would say, when we misuse law that way, or we misuse medicine that way, or we misuse anything that way, we could tell we're doing it correctly if it brings us closer to something more fully human, something more fully just, something more fully integrated, rather than away from those things.
Yeah, that makes a lot of sense. With all this new emerging technology comes a lot more racial disparities, economic disparities,
Yeah.
etc. Right? Um, so
Yes.
with the rise of new technology, comes new issues within neuroethics, right? What do you believe will require our attention in the next few decades, and how do you think we'll be dealing with these new technological problems in the future?
Yeah. I think for anyone going into medicine right now, I would say, make a beeline for psychiatry. There's going to be a much greater need than ever before, and there is an increased need now. But I think with different neurotechnologies, we will have better access, more capability to do things. Things will be computed faster. I worry that actually the fundamental things that make us intelligent as persons, the ability to struggle through solving a problem, the ability to have a human experience would be replaced by something like neuro AI, chip or computer system that can solve a dilemma for you so that you have more time for whatever else that you need. I worry that those things, under the auspices of making us more fully human or more equitable or more compassionate, more prone to make good decisions, will slowly disintegrate who we are as emotional beings. And so, with any such progress, we always have to ask, um, what are we willing to sacrifice as a population in order to gain the benefits of this new technology? Um, so I think about things like Neuralink or Neuro AI, things that will help us to become more efficient in many ways. But I always ask, sort of at what cost, um, and for what purpose? What ultimately is the goal? Um, and I don't think, even with these emerging technologies, that the ultimate goal is always so clear, right? So it can help us process things quicker. That's great. In order to do what? Really to process more things more quickly. But what's that for? It just seems like an infinite regress until we're able to understand what are we trying to do as human beings? What are we trying to evolve into? What's the ultimate goal? Um, and if in pursuit of that goal we lose everything that we stand for, I think again we've just created problems. We're not where we want to be now, and so we get where we want to be, but we've lost everything that we are in the meantime.
I think that also circles back to your, what you explained earlier, right? Bad memories are memories still. Like we
Yes.
may think like those are bad things, so we want to get rid of them, and we think, oh, it's gonna make a more holistic, more whole human individual. But as you mentioned, the reality doesn't really work that way because bad memories still comprise a large part of who we are as a human being. So, and even though like we may try to disentangle them, they may exist somewhere in our, deep unconsciousness. And when it manifests itself, then not only are we, like not only do we encounter the problem, we also lost its cause. So I think
Exactly.
right. So in a similar regard, I think it's also like kind of interesting to think about these things because we try to make things better, but at the same time, we're not gods. We can't predict what exactly is going to happen. We make decisions based on the things we currently know, but after like the thing has been implemented, for example, all the technological advancements, well, it's pretty irreversible, right? Because we're already used to that. It's already so deeply ingrained into who we are. And if we try to remove them later on, it's going to be extremely difficult because there are people who are willing to stay. So it's just makes more problems. Um, and so in that regard, actually, what advice would you offer for those who are willing to enter into a neuroethical field?
Yeah, I would say run as fast as you can toward it. It's extremely rewarding to think about the theoretical and practical implications of contemporary neuroscience and sort of where that will go in the future. That it really does matter who we become as persons, that um, our moral development truly matters. And if character formation is important, if becoming more fully human is important, then neuroethics is the field for you. Understanding why we do what we do, why we do it, when we do it, what is the ultimate purpose for our actions, and then understanding how we solve problems and what are the mechanisms with which we solve problems so that we can solve them better the next time we encounter them, I think is really, really important. And if for people that are very interested in sort of the metaphysical realm of things, neuroethics is the place to be, right? You're using an organ to contemplate that same organ. You're not going to be able to have that experience anywhere else. But I could think of nothing more important than overseeing the moral development of the minds of those who will live after us. And I think we have an enormous responsibility to leave the world um, better than we found it.
That sounds great, actually. Wait, sorry. One second. Yeah, sorry about that. There's a lot of noise. But just leading from
Okay.
that, how exactly has mentorship allowed you to influence your own personal career? And how would you actually approach mentoring others within the field of neuroethics and neuroscience and just beyond?
Yeah, mentorship has played a really important role for me. So I've been extremely lucky. I can tell you that, 90% of my colleagues had a dissertation director who was, extremely hands-off, expected them to do everything. And then when they brought their ideas to that professor, tore it to shreds, start over. Um, so having a good mentor who really does want the best for you, who encourages you to treat yourself like someone you're responsible for helping, it is so important to be able to look at both a good role model, not just intellectually, but morally as well. Having somebody that you admire, that you respect, it is really, really important. I've been blessed with a number of those mentors over the years, and really the key is to that sort of unity in the mentorship relationship is being willing to take the time, and being willing to waste time productively together, right? To say, let's just talk about what your interests are. Where do you want that to go? But also making sure that you look at your mentee as a human being, not just as somebody who's working on this research project. Um, Asking about their family, asking about their family again the next time. Oh, how did that appointment go? What's going on? So not just taking a personal, professional interest, but really taking a personal interest. I had that all throughout my academic career, and really it's made all the difference in how I approach my students. The goal for me is to treat each student as if they were my only student, to teach treat each meeting or each interaction like it's the only one that I'll have that day, right? Doing that consistently over time as a great leadership quality that you can instill in younger generations to say, this person was the only one in my life who actually took the time. They asked about my mom, right, who was undergoing a procedure. I was really nervous that day, but it just made a difference, right? It's small for you, but it makes a big difference for them.
I could definitely see a lot of those same qualities in this meeting too. Like the professionalism that you've held today is like very great, and it's not something
Oh,
that many
thank you.
people see like in everyday, day to
Oh,
day.
thank you so much. Likewise, I wish that I had students like you.
Yeah, also, I think it really is important, right? Those small things that people may easily overlook because they think, oh, like we just gotta get the work done and move on. But all these like little things that seem little, but looking back, like that's I think what people do remember. It sticks in their head, and when you like meet them a long time after, they still remember you. Like, and that's how if that's how they remember you, well then, that's a great thing. I guess as a human being, not just as a researcher, not just as an ethicist, but as a human being. So,
Yeah,
yeah, I appreciate that advice as
Yeah.
well.
Yeah, no, of course, there's sort of the old saying that, people will forget what you said, will often forget what you do, but will never forget how you made them feel,
yeah,
right? And the key to healthcare, any good physician will tell you that, patients don't care how much you know until they know how much you care, right? You got to make the personal connection first, or else why would I trust you, or why would I believe you? And so it's got to start with a personal relationship and work outward that way, rather than starting from the outside, maybe getting to the inside.
yeah. Of course, and not only that, we'd like to also thank you for the time you took today to come up here and sit with us to just talk about neuroethics and just your whole career in general and how you've.
Oh, it's truly my pleasure.
Yeah, it was really great to have you here today, and we'd like to thank you for your time.
Yeah, thank you so
Of
much.
course. Yes, thank you both so much. It's an honor, of course. If there's anything that I could do for you or for your listenership, please don't hesitate to send them my way. Um, however I can help. But thank you for the good work that you're doing. And
Yeah,
I'd wish you the best of luck during finals, but I'll reserve that right to that wish for those who need it. And you certainly don't.
Yeah, thank you.
thanks a lot.
And yeah, the interview, after it's being done, we're gonna process it, both the script and the video. And after it's being done, we're gonna upload it to our website, and then we'll let you know. We're also gonna make a
Great.
post. Keep an eye
Yeah,
on that, please. Yeah.
Perfect. All right. Thank you so much. I really appreciate the time.
yeah, thanks a lot.
Thank you
We
so
hope
much.
you have a great day.
Thanks, you too. Take care.
Bye.